Before we begin, don't forget to subscribe and hit the like button to support the channel and stay updated on more historical stories. The persecution of people with disabilities, the T4 program, and the forgotten victims, wild euthanasia, war, and the road to mass extermination after the end, when the killing continued. In August 1941, the central euthanasia program was officially halted. The gas chambers in the killing centers were shut down, transports were reduced, and the regime announced, without public explanation, that the policy had ended. On paper, the mass killing of disabled people was over. In reality, it was only transformed. What followed is often described as wild euthanasia, a decentralized phase of killing that continued throughout the war. Without a single coordinating office like Action T4, doctors, nurses, and administrators were given broad discretion to decide who would live and who would die. Patients were no longer transported to specialized killing centers. Instead, death occurred inside ordinary hospitals and care institutions. The methods were quieter and less visible: deliberate starvation, denial of medical care, overdoses of sedatives, and lethal injections disguised as treatment. This phase claimed tens of thousands of additional lives. Medicine without rules. During the war years, the boundaries of medical ethics collapsed almost entirely. Doctors operated in a system where killing had already been normalized and where accountability was minimal. The earlier authorization from the leadership had sent a clear message: some lives no longer mattered. Medical staff often justified their actions by citing wartime conditions. Food shortages, overcrowding, and lack of resources were used as excuses to neglect disabled patients. Those who could not work, communicate clearly, or improve were the first to be deprived of nutrition and care. Death became a slow administrative outcome rather than an immediate event. Patients weakened gradually, lost weight, and died from infections that were easily treatable under normal circumstances. On paper, everything appeared natural. This method of killing had an additional advantage for the regime. It left fewer traces and required less coordination. The war as cover. The Second World War created an environment in which death became omnipresent. Bombings, casualties, and displacement dominated daily life. Against this background, the deaths of institutionalized disabled people attracted little attention. Families were often separated by war, unable to visit relatives in distant institutions. Communication was limited. Letters were delayed or censored. Many families never learned the true fate of their loved ones. The war also provided ideological justification. The state argued that every resource had to be directed toward victory. Caring for those who could not contribute was framed as wasteful. This logic extended earlier arguments about economic burden into a total wartime mentality. In this context, killing was no longer presented as exceptional, it was presented as necessary. From disabled patients to occupied territories. As the war expanded, so did the scope of killing policies. Techniques and personnel developed during the euthanasia program were exported beyond Germany's borders into occupied territories. Doctors and administrators who had gained experience selecting and killing disabled patients were transferred to new assignments. They carried with them not only technical knowledge but also psychological conditioning. They had learned how to kill without seeing themselves as criminals. This transfer of expertise marked a critical transition. What had begun as a policy targeting disabled citizens became a foundation for mass extermination on a far greater scale. The human experiment of dehumanization. One of the most dangerous aspects of the euthanasia program was not the technology itself, but the mental transformation it produced. By redefining people as biological problems rather than human beings, the regime trained professionals to suspend empathy. Forms replaced faces. Diagnoses replaced names. Files replaced lives. This process created a new type of perpetrator. Not a sadist or fanatic, but a bureaucratic killer who followed procedure and believed in efficiency. Such individuals did not see themselves as violent. They saw themselves as responsible. This mindset would soon be applied to entire populations. Personnel transfer and escalation. Several individuals involved in euthanasia operations later played key roles in extermination camps. The gas chamber technology, the deceptive language, the logistics of transport, and the disposal of bodies were all refined during earlier killings. Facilities like Auschwitz-Birkenau did not emerge in isolation. They were built upon lessons learned in hospitals and care institutions. The victims changed. The scale changed. But the underlying logic remained the same. The state claimed the right to decide who deserved to live. The silence of society. Despite rumors and partial knowledge, widespread resistance never emerged. Some individuals opposed the killings privately. Others helped patients survive by hiding them or falsifying records. But these acts were rare. Most people adapted. Fear of punishment, belief in authority, and emotional exhaustion contributed to silence. The persecution of disabled people remained largely invisible compared to other wartime events. This silence was not always agreement, but it was enough to allow the killings to continue. Disabled soldiers and a bitter contradiction. One of the most striking contradictions of the period was the treatment of disabled veterans. Soldiers wounded at the front were often celebrated as heroes, even when they suffered severe disabilities. Yet civilians with similar conditions were considered burdens. Their lives were judged differently based on perceived usefulness and symbolism. Disability itself was not the deciding factor. Value to the state was. This contradiction revealed the true nature of the ideology. Human worth was conditional. The end approaches. As the war turned against Germany, institutions descended into chaos. Bombings destroyed hospitals. Staff fled or were reassigned. Records were lost or deliberately destroyed. In some places, killings intensified as staff attempted to resolve patient populations before retreat. In others, neglect increased as food and medicine disappeared. When Allied forces finally entered these institutions, they found survivors who were severely malnourished, traumatized, and abandoned. Many had no family left to return to. The forgotten survivors. Survivors of institutional abuse faced a difficult post-war reality. Many were never acknowledged as victims. Compensation programs often excluded them. Their experiences did not fit dominant narratives of suffering. Some remained in institutions long after the war, continuing to live under restrictive conditions. Others were released into societies that preferred not to remember what had been done to them. Their survival was not a victory. It was another form of isolation. Conclusion. A bridge to greater crimes. The killing of people with disabilities did not merely precede later mass atrocities. It made them possible. It trained perpetrators, tested methods, and weakened moral boundaries. Understanding this history means recognizing that genocide does not begin with camps or mass graves. It begins with ideas, language, and decisions made quietly in offices and hospitals. The victims of these policies were not only the first to die, they were the first to be erased. The collapse and the question of responsibility. When the war in Europe ended, the physical machinery of killing had largely been destroyed or abandoned. Institutions were in ruins, records were missing, and many perpetrators had disappeared into civilian life. Yet the moral question remained unanswered. Who would be held responsible for the systematic killing of people with disabilities? Unlike the destruction that occurred in camps later in the war, the euthanasia program had been carried out largely within hospitals, clinics, and state institutions. Its perpetrators were doctors, nurses, administrators, and civil servants, people whose professions were meant to protect life. In the immediate aftermath of the war, Allied investigators uncovered fragments of the truth. Documents, testimonies, and surviving patients revealed that the killing of disabled people had not been accidental or isolated. It had been deliberate, organized, and sanctioned at the highest levels. Yet accountability would prove limited. Trials without closure. Some individuals involved in the euthanasia program were prosecuted. A small number of doctors and administrators faced trial, and a few were sentenced. These proceedings established an important legal precedent. Killing carried out under the guise of medicine was still murder. However, most perpetrators were never tried. Many claimed they had only followed orders. Others argued that their actions were legal under the laws of the time. Some simply returned to private practice, continuing medical careers with little interruption. The destruction of records and the decentralized nature of later killings made prosecution difficult. The euthanasia program, including Action T4, never received the same level of legal scrutiny or public attention as later mass crimes. For decades, it remained on the margins of historical justice. The silence of post-war society. In the years after the war, many societies focused on reconstruction and recovery. There was little appetite for confronting uncomfortable truths, especially those involving respected professions like medicine. Families of victims often received no official acknowledgement. Many never learned how or why their relatives died. Death certificates remained uncorrected. Files stayed sealed. Silence became the norm. Disabled survivors faced an especially harsh reality. Their suffering did not fit dominant narratives of heroism or resistance. Many were still institutionalized, living in the same or similar facilities where abuse had occurred. Others returned to communities that preferred not to ask questions. The message was clear. This chapter of history was inconvenient. Exclusion from recognition and compensation. For decades, people persecuted under euthanasia policies were excluded from victim recognition programs. Compensation schemes focused on other categories of persecution, often ignoring those killed or harmed because of disability. This exclusion reflected deeper societal attitudes. Disability was still stigmatized. Survivors were often seen as patients rather than victims. Their testimonies were discounted or ignored. Only in the late 20th century did this begin to change. Historians, activists, and families pushed for recognition. Memorials were established, official apologies were issued, files were opened. But for many, these gestures came too late. Remembering the victims as individuals. One of the most significant shifts in recent decades has been the effort to restore individuality to the victims. Rather than anonymous numbers, historians began to recover names, photographs, letters, and personal histories. This work revealed lives interrupted rather than abstract cases. Children who liked to draw. Adults who worked, loved, and hoped. Elderly people who had survived earlier hardships only to be killed by their own institutions. Remembering these details challenges the language that made the killings possible in the first place. It resists the reduction of human beings to diagnoses. Memory, in this sense, becomes an act of justice. Medicine confronts its past. The medical profession has been forced to confront its role in these crimes. For many years, this reckoning was incomplete or defensive. But gradually, professional organizations began to acknowledge that doctors were not merely victims of a system. They were active participants. Medical schools incorporated this history into ethics education. Professional codes were revised. The principle that every human life has inherent value, regardless of ability or productivity, was reaffirmed. Yet remembrance alone is not enough. The lesson is not simply that this happened, but that it happened with the cooperation of educated professionals who believed they were acting responsibly. Why this history still matters. The persecution of people with disabilities is not only a story of the past. It raises questions that remain relevant today. Who decides the value of a life? How does language shape perception? What happens when efficiency and utility replace empathy? Modern societies continue to debate issues related to disability, healthcare resources, and quality of life. These debates are not inherently dangerous, but history shows how easily they can become dehumanizing when detached from ethics and human rights. The euthanasia program demonstrates that extreme violence does not always begin with hatred. Sometimes it begins with administrative decisions, medical terminology, and silence. The danger of forgetting. Forgetting is not neutral. When societies forget how ordinary people became perpetrators, they risk repeating similar patterns under new circumstances. The victims of these policies were among the most vulnerable members of society. Their exclusion from memory mirrored their exclusion from life. To remember them is to affirm a principle that was denied, that human dignity is not conditional. This is why remembrance must include those who were once deemed invisible. A final reflection. The story of the persecution of people with disabilities challenges comforting assumptions about progress and morality. It shows that education, professionalism, and modern institutions do not automatically prevent cruelty. What protects society is not technology or efficiency, but ethical commitment and the courage to resist harmful ideas, especially when they appear reasonable or necessary. The victims were not enemies. They were not threats. They were people. Conclusion. Restoring what was denied. This history does not end with trials or memorials. It ends, or continues, with a choice. The choice to recognize every human life as worthy of protection. The choice to question authority when it devalues the vulnerable. The choice to remember those who were erased. The first victims were not forgotten because they were unknown. They were forgotten because remembering them was difficult. Remembering them now is an obligation.